Just tasked our first speaker with trying to reduce his moderated abstract time from 7 minutes to 5, which is going to really curtail things for him. No, literally, we'll do our best to try and catch up a little bit of time. But if you can take your seats, please, so we can start. So I'm delighted alongside my co-chairs for this session to start with the moderated abstracts. And first up is Nicholas Jacks. Over to you, if we can.
Thank you. It's a pleasure to be here. Thank you very much for the invitation to speak to you today. So my name is Nick Jacks. I'm a cardiology registrar from the Leeds General Infirmary, and I'd like to present a summary of my research looking at the impact of comorbid type 2 diabetes in patients with hypertrophic cardiomyopathy, and hopefully I can convince you in 5 to 7 minutes that this is a bad combination. So we know that type 2 diabetes occurs in around 9% of patients with HCM, and that when it coexists, we get worsened diastolic function, higher NYHA functional class, and increased long-term mortality. And although these are two distinct pathological entities, they share common features of microvascular dysfunction, depletion of myocardial energetics, and increased myocardial fibrosis. So our hypothesis was that when these two conditions coexisted, we'd see greater reductions in energetics, worsened perfusion, and increased scar burden. So this was a single-center observational case control study in Leeds. So we screened 426 patients who had a diagnosis of HCM for coexisting diabetes. So our final cohorts, we had 20 patients with combined HCM and diabetes, 20 with isolated HCM, and 15 healthy volunteers. All patients had undergone genetic testing at baseline, and our groups were matched for age, sex, and ESC risk score. We excluded anyone with coronary artery disease, cardiac surgery, smokers, and contraindications to CMR imaging. So what do we mean by myocardial energetics? What does that mean? So we're trying to non-invasively measure mitochondrial function, metabolic function within the myocardium, and we do this using a technique called phosphorus spectroscopy. So what we can do is we can measure the relative concentrations of different phosphorus-containing metabolites within the myocardium, and this gives us a sort of sensitive state index of the energetic state. So we're interested in phosphocreatine and ATP, as you can see there. So we place a voxel over the mid-ventricular septum in diastole, and we get the spectra, as you see there. And the ratio of phosphocreatine to ATP tells us about the underlying state of the myocardial energetics. So in addition to phosphorus spectroscopy, we put our patients through a comprehensive CMR protocol, which included stress perfusion imaging and also scar imaging as well. So in terms of assessing microvascular function, we did this using quantitative myocardial perfusion. So what does this mean? So this means we're measuring the myocardial blood flow at both stress with adenosine and also at rest. And although this technique is not used clinically, it has been shown to correlate with predictors of cardiovascular outcomes. So with the prevalence of type 2 diabetes in our population in Leeds was around 14%, which is slightly higher than registry data, but probably just reflects a good Yorkshire lifestyle. And our groups were matched for age, sex, and ethnicity. You can see our HCM groups were matched for HCM phenotype, for ESC risk score, and for the presence of sarcomeric mutations, which occurred around 33% in the isolated HCM group and 30% in the HCM and diabetes group. So our patients with HCM and diabetes had increased plasma NT-proBNP levels. They had worsened NYHA functional class, and not unexpectedly, BMI was significantly increased. In terms of cardiac geometry and function, we didn't see any significant difference in ejection fraction, mass, or wall thickness between the groups, but what we did see is worsened left atrial function in patients with HCM and diabetes, worsened reductions in global longitudinal strain and diastolic strain parameters. Here you see the stepwise decline in GLS from healthy volunteers through to patients with HCM and diabetes. So in terms of myocardial energetics, we did see significant impairment in patients with combined HCM and type 2 diabetes. So phosphocreatine to ATP ratio, which is what we're interested in, was significantly reduced compared to both healthy volunteers and isolated HCM patients. Similar story for myocardial perfusion. So stress myocardial blood flow was significantly reduced in the HCM and diabetes group, with a mean stress MBF of 2.06 in healthy volunteers, falling to 1.74 in isolated HCM, and then dropping to 1.39 in HCM and diabetes. Here you see some examples of the perfusion maps that we get with quantitative perfusion, just to exemplify the problem. So you see on the far left of the screen, nice normal perfusion in a healthy volunteer with a mean blood flow of around 2.06, and then a marked decline in perfusion when you get a combination of HCM and diabetes. In terms of fibrosis, so we saw significantly increased myocardial scar burden in patients with HCM and diabetes. So the mean scar percentage was 4% in isolated HCM patients, climbing to 10% in patients with combined HCM and diabetes. So the study's got several important limitations to bear in mind. So it's a single center, small sample size. Important to note that the phosphorus spectroscopy technique that we used is not licensed for patients with ICDs or pacemakers, so we had to exclude this set of patients from our study. We had a relatively high prevalence of apical HCM in our cohorts, but that is increased in the diabetes population. And it's important to remember that we can't completely exclude the impact of occult coronary artery disease from our findings. So in conclusion, HCM patients with type 2 diabetes display greater reductions in myocardial energetics, worsened perfusion and contractile function, higher myocardial scar burden, and increased BNP levels. And these adverse phenotypic features may be important components of this adverse clinical manifestation that we see when these two conditions coexist. Thank you very much for your attention. I hope that was on time.
Fantastic. Thank you very much for a super quick talk. Any questions from the floor? One from Richard in the booth up the top, I see.
Yeah, great talk. Thank you very much. Did you? Oh no, I'm going to ask a question. You're not getting away that easily. Yeah. Did you see any relationship between HbA1c and your outcomes? And in the non-diabetic, was there any relationship between BMI and the outcomes?
Yeah, so BMI does seem to correlate with energetics, as does HbA1c. So unpicking that relationship is challenging. But
yeah, no, they're very interesting. Yeah. Great. Well, thank you very much. Okay. Oh yeah, that's right. Yeah, so we go on to the second one. So Daniel Hammersley is going to come and talk to us about abnormalities in patients with DCM in clinical remission. Thanks, Daniel.
Great, thank you very much, and thank you for the invitation to speak today. So I'm a cardiology registrar at King's College Hospital, and I'm presenting work from my PhD at the National Heart and Lung Institute and Imperial College in the Royal Brompton. The title of my talk is Structural Functional Myocardial Abnormalities in Patients with Dilated Cardiomyopathy in Clinical Remission. Most, if not all of you, will be involved with the management of patients with dilated cardiomyopathy, so will be familiar with the concept of left ventricular reverse remodeling in these patients. In short, this is the process by which patients undergo favorable cardiac remodeling such that the dilatation and cardiac systolic dysfunction which characterizes this disease improves, principally in the context of modern heart failure therapies. Our group at the Brompton have previously studied patients who've undergone substantial left ventricular reverse remodeling in the TREAD-HF study, which was led by Brian Halliday, who's here today, and Professor Prasad, whereby patients who'd undergone recovery of cardiac function, had no symptoms, and normalized NT-proBNP, had heart failure therapies sequentially withdrawn. Of course, this study showed that a substantial proportion of these patients had relapse of their dilated cardiomyopathy, and on account of this, one of the conclusions was that these patients have a state of clinical remission from their disease rather than cure. However, there's very limited data on dilated cardiomyopathy in clinical remission, and a number of important questions remain. These include what proportion of patients will go on to reach clinical remission from DCM, which patients does this happen to, what are the mechanisms of remission, and do these patients have residual subtle phenotypic abnormalities? In order to answer some of these questions, we designed a study called the REMIT DCM study, which stood for Reverse Remodeling and Remission Markers in the Serial Evaluation of Recent Onset Dilated Cardiomyopathy. This was a pilot observational cohort study, and we recruited 70 patients with recent onset DCM and studied them at 3 time points over 12 months, baseline, 3 months, and 12 months. On each occasion, in each study visit, patients had a cardiac MRI, conventional biomarkers including NT-proBNP, experimental biomarkers including proteomics and metabolomics, and health questionnaires to assess symptoms. We also undertook genetic sequencing at baseline. Our primary endpoint was clinical remission from DCM at 12 months, in order to meet this endpoint, patients had to have an improvement in their ejection fraction by 10% to a value greater than 50. They had to have reduction in LV end-diastolic volume index to within the normal range, resolution of symptoms as identified by NYHA class 1, and normalization of NT-proBNP as a value less than 250. And our aim was to study the characteristics, imaging, and molecular biomarkers of DCM remission. We recruited patients with DCM who'd been diagnosed within 6 months with an ejection fraction at baseline of less than 45 and excluded patients with coronary disease, active myocarditis, alternative cardiomyopathies, or adverse loading conditions or pregnancy. We screened just under 300 patients and recruited 70 and 33 age and sex matched healthy volunteers, and 67 of these patients completed follow-up. And with the follow-up visits, we undertook just under 240 study visits to assemble this cohort. The cohort was predominantly men, as with most DCM cohorts, and the median age was 51. At the time of their first study visit, the median time since their DCM diagnosis was 36 days, so this was a fresh cohort with newly diagnosed DCM. Most patients were NYHA class 2 or 3. The median NT-proBNP was high at just under 1,400. A high proportion were treated with prognostic heart failure therapies at baseline, and a very high proportion at 12 months, with the exception of SGLT2 inhibitors, which were not guideline recommended for a significant proportion of the study period. The mean LV ejection fraction was 30% at baseline, and a fairly high proportion of the cohort had myocardial fibrosis on late gadolinium enhancement CMR. In terms of our primary outcome, we found that 21 patients, which was just under a third of the patients, met the primary endpoint of clinical remission at 12 months. And in considering the individual components of this combined endpoint, a higher proportion met each of these. So just under half had an ejection fraction of over 50%, and 2/3 had normalized LV end-diastolic volume index and had no symptoms. Interestingly, we found that no baseline clinical or CMR parameters predicted the 12-month remission in this cohort, in keeping with observations from clinical practice. And when we used a machine learning algorithm to combine variables using a technique called elastic net regression, we found that we were still only able to find at most moderate level of discrimination for the primary endpoint using these conventional variables. When we looked at the longitudinal changes in patients classified by whether they went on to meet clinical remission or not, we observed changes in parametric mapping. Most notably, at 12 months, we saw that the patients who went on to clinical remission had lower native T1, lower ECV, and lower T2 values than those that did not. A cautious interpretation of which may be that there's a role for regression of interstitial fibrosis and reduction in myocardial inflammation in patients that go on to clinical remission. Interestingly, we found that 50% of the patients that went on to clinical remission had myocardial fibrosis at baseline on their CMR, and there was no change in this, as one may expect, from baseline to 12 months. That was in terms of presence, the extent of myocardial fibrosis, the position, and the pattern. So fibrosis does not preclude remission from DCM. When we compared the patients who were in remission at 12 months with the healthy volunteer cohort, we found that subtle abnormalities persisted, including slightly lower left ventricular ejection fractions and slightly higher LV volumes, and more substantially abnormal LV strain values. The right ventricular size and ejection fraction was not different between the two groups, but RVGLS was lower in patients with DCM remission. Patients with DCM remission also had higher LV mass index, which was principally driven by higher LV matrix mass and to a lesser degree LV cellular mass. And there was higher native T1 values and a trend towards higher ECV in the patients with DCM remission compared to HVOLs, but no difference in T2 values. So in summary, we found that nearly a third of patients with recent onset symptomatic DCM were in clinical remission at 12 months of modern therapies, and there were no conventional clinical CMR variables that predicted this phenomenon. DCM remission did appear to be associated with regression of interstitial fibrosis and a reduction in subclinical myocardial inflammation, and these may represent therapeutic targets. DCM remission was distinguishable from healthy volunteers by CMR due to subclinical dysfunction of both ventricles and increased LV mass, which was driven by higher matrix mass. And replacement fibrosis was a common feature of DCM remission and persists on longitudinal follow-up. Our future work will focus on evaluating whether these observed structural, functional, and myocardial abnormalities predispose to relapse from the disease in the future, and on integration of our molecular data, which we'll be presenting at conferences later in the year. Thank you. I'd be delighted to take any questions.
Great presentation, thank you. Any questions from the floor? No questions? Okay, well, thank you very much indeed. That was a wonderful presentation. Thank you.
Will talk to us about physical activity and how it modulates the effect of the Titan variant associated with right ventricular and diastolic volume.
Hello everyone, my name is Mihir Sanghvi. Thank you very much to the organising committee for this chance to speak. A slight change of pace here as I present this small gene lifestyle interaction concerning physical activity and right ventricular and diastolic volume. So what is gene lifestyle interaction? So one clinical problem that we see all the time is that a group of people with the same risk factors, the same variants, they don't all express a disease equally. And for me, I feel it's completely intuitive that lifestyle has a profound effect. Your environmental factors have a profound effect on your eventual clinical phenotype. But genetic studies are performed in complete isolation to any environmental variability. The gene lifestyle experiments are a mechanism by which we can try to examine this interplay within a formal framework. So this 3D bar chart here, if we take the y-axis, which is your disease trait, and then your x-axis, which is your genotype or the number of risk alleles that you possess, and then here on our z-axis we have our lifestyle factor, we can see that your genetic risk is significantly attenuated once you stratify by a lifestyle factor. The main issue with gene lifestyle experiments is that it requires a massive sample size. Interaction effects are always more difficult to detect than main effects, and therefore we need statistical power, which means large sample sizes, and that can often be problematic. One of the most striking examples within ICCs of this gene lifestyle interaction is with physical activity. Dr. Kasky presented the data on the new guidelines, and this is from the sports guidelines from the ESC, but we know that physical activity needs to be restricted in cases of ACM or DCM. And so my thinking was, with the sample size limitation that we have, would it be possible to design a gene lifestyle experiment to investigate this, even if it was in an indirect fashion? So we know that for ARVC, assessment of the right ventricle forms a really important part of the diagnostic pathway. In the UK Biobank, we have CMR examinations at population scale. These are contours that I drew as part of the Biobank core lab when I was in FY2, and then from that we were able to develop these AI tools which have led to automatic segmentation of our cardiac MRI scans for volumes. And with those AI tools, we've now scaled up and we have approximately 45,000 scans analyzed within the biobank. Last year, we published this right ventricular GWAS for the right ventricle. The SNP-based heritability was studied 1%, and for right ventricular end diastolic volume, we identified 10 loci. So putting all that together, is there any overlap, therefore, when we think of RV-EDV, when we think of rhythmogenic, when we think of dilated cardiomyopathy? And we can see that we have two loci, Titin and BAG3, that overlap across all the different conditions and phenotypes. So that's all the background. So what did I actually do? So I looked at the genome-wide data for all the participants in the UK Biobank, extracting the number of risk alleles for each variant associated with right ventricular end diastolic volume. For physical activity, we took the self-reported questionnaire data regarding individual physical activity levels and combined these into a metabolic equivalent of tasks, or METs, and we dichotomized this, taking the top quintile as being most physically active and the remainder as the others. And then we ran this, I ran this interaction model. So right ventricular end diastolic volume is your outcome. You have your SNP term, your physical activity term, and then your interaction term. So how does the effect of your SNP or your genetics on our outcome, RV-EDV, vary depending on the level of physical activity? And then we included these covariates here. We used unindexed right ventricular end diastolic volume and adjusted for height and weight in the model. So just over 42,000 individuals which had paired CMR, physical activity, and genetic data. And as is typical in these sorts of experiments, we restricted the analysis to those of European ancestry. And then looking at the results, so here I present the data just for our variants that overlap with the clinical syndromes. And for the Titin locus, which is our interesting result, we can see that when we look at our interaction term, which is this column here, physical activity significantly attenuates the association between our tight invariant and right ventricular end diastolic volume. So 0.914 mils represents a difference in the RV-EDV increasing effect of the risk allele between those who are physically active and those who are not. And if we look at this another way, we can say that the magnitude of effect of the tightened risk allele on end diastolic volume is 1.7 times larger in physically active individuals compared to others. So in summary, this is the first study to really examine the interaction of lifestyle on genes involved in cardiac structure. Physical activity attenuates the association of this tight invariant. And all that aside, I think what I really want to highlight, commentary about the choice of variant and all that sort of thing aside, there's a potential in this methodology in explaining some of the clinical variability that we see and how we can potentially account for some of that. Evidently, it'd be much more preferable to study in cardiomyopathy cases themselves, but as our sample sizes grow, as our phenotyping becomes deeper, this might be something that we're able to achieve in the future. And clearly for these results, external validation is required, and that's something that we're working on at the moment. So with that, I'd like to just thank the following people. Thank you very much for your time, and if there are any questions, more than happy to take them. Thank you.
Thank you. That's a really innovative topic. Any questions from the audience? Antonio.
Sorry, can I be that guy?
Of course.
Why that particular variant and not all truncating variants?
Yes. So we're talking about just the genome-wide data within the biobanks. We're not looking at exome or the rare variants. So and bioinformatically, it's quite difficult to do this with the truncating variants, and there weren't enough. So when we look at the rarer variants, etc., that's something that we're going to explore. But whether this framework can be applicable to that is something that we still have to sort of look into. But it's a really interesting thing to think about, definitely.
Thank you very much.